This is Peter Boland, and you're listening to More Health, Less Healthcare. Today, I'd like to talk about a word that once you hear it, you can't unhear it. It's weathering. And weathering isn't just about feeling stressed or tired or burned out. It's a clinical, physical, and societal diagnosis of what our systems are doing to people's bodies, especially women's bodies, long before they ever show up, or prenatal or cardiology consult. It forces employers, health plans, and delivery systems to answer a harder question than we usually put on a PowerPoint slide or a presentation. Namely, are we actively slowing that damage or quietly helping it along? So in this episode, I want to try and address three things. First, I want to use plain language to describe weathering and what's actually happening in the body, in the clinic, and in people's mental health. Second, I want to connect weathering directly to maternal health and birth equity, because you can't make sense of the Black maternal mortality crisis without it. And third, let's turn the camera back where I think it belongs, on employers, health plans, and delivery systems. Not as villains or saviors, but as active participants in either accelerating or relieving weathering. In other words, are we in the weather business or are we in the health business? So let's start with the body. Weathering in the body is when stress becomes biology. Weathering is what happens when chronic grinding stress stops being just a feeling and starts being your biology. The stress hormone is designed, for emergencies. Something jumps out at you on the freeway, your nervous system snaps to attention, hormones surge, your heart rate spikes, your blood pressure, the vessels tighten, your brain focuses. And once the danger passes, the system is supposed to stand down. Now, all that in the span of 2 or 3 minutes. But weathering is what happens when the danger never really passes. When racism and economic insecurity, surveillance at work, low-wage jobs with unpredictable hours, unsafe neighborhoods, and constant bureaucratic friction all tell your brain, stay on guard. Over time, the body pays for it. Blood pressure runs higher, even at rest. Inflammation smolders, blood vessels stiffen, glucose control gets worse, and the cardiovascular and immune system age faster than they should. Well, let's use an example. By the time a woman becomes pregnant, particularly in neighborhoods pushed to the margins by decades of policy choices, her body may already be carrying years of unrelieved strain. Clinically, this shows up in a number of ways. Earlier and more aggressive hypertension, higher rates of diabetes, kidney disease, autoimmune conditions, and more complicated pregnancies and higher risk of life-threatening events around childbirth. Now, the maternal health gap is not just about what happens during 9 months. It's what about the prior 20 or 30 years that have done to the body that has had to fight harder and harder for basic safety and stability. That's the physical face of weathering. It's corrosive and damaging to each organ in the body. But if you stop there, you're going to miss most of what exam rooms actually see. So now let's look at that. I'll call it clinical and mental health, what exam rooms miss. And from a clinical standpoint, weathering is the backdrop to routine visit, especially in maternal health. The numbers on the blood pressure cuff, the lab results, the weight gain, the pattern of missed appointments. These are all often the final inputs of a life lived under constant pressure. And oftentimes we ignore that. We misread the room and who's in it. And we seem non-compliant. The patient would seem non-compliant. We judge them as non-compliant. That's how we label some patients. Where we should see this, whatever their behaviors are, as perceived behaviors, as survival strategies. We see late to care where we should maybe more accurately see a woman juggling 3 jobs and childcare, transportation deserts, and a prior experience of not being believed by clinicians. Mental health is not a separate chapter here. It's braided through the same process. Living with chronic racism, economic insecurity, unstable work conditions shapes how the brain scans for danger and how the body reacts. Anxiety, depression, sleep deprivation and disruption, and even hypervigilance are not just comorbidities. They're part of how weathering takes hold. And if you spent years not being believed in a medical setting, every clinical encounter carries an extra amount of emotional charge. So when a pregnant patient seems guarded or skeptical or is checking every instruction twice, that may be a rational response to prior harm and not necessarily a personality flaw. So when clinicians and social workers and mental health professionals don't see weathering, they risk interpreting those survival strategies as resistance or manipulation or somatization. And when leadership teams don't see it, they keep investing in the wrong fixes. More apps, more pamphlets, more engagement campaigns, more encouragement, like at a girl, to be resistant, basically to be resilient, to use the employee assistance program to do mindfulness, maybe on your lunch break. And at the same time, the baseline stress they're asking people to carry remains untouched. Weathering asks, I think, a really blunt question. Is our system lowering the load in people's lives or adding to it? With a smile and a wellness logo. Well, let's turn to societal weathering, or policies that are a slow motion harm across the board. At the societal level, weathering is what you get when housing policy, wage policy, education funding, policing, transportation, and healthcare all lean in the same direction for a long enough time to create real and lasting harm. So redlining just doesn't affect home ownership. It affects the air that people breathe, the food they can buy, and the safety of their streets, and the time they spend commuting. All those conditions cascade into the body. So when we talk about maternal health disparities, we tend to jump straight to the hospital door. Weathering says, step back and open your eyes wider. Look at the neighborhoods where women grew up, the schools they attended, the jobs they had to take, the care they could or couldn't afford, the ways their pain and concerns were discounted. These are not side notes. They're the upstream drivers of who shows up at your delivery unit already closer to the edge. And this is why weathering is so uncomfortable for healthcare leaders and clinicians to look at, digest, and talk about. It says your excellent OB program, your simulation trained teams, your multidisciplinary rounds can't fully compensate for a world that has already been grinding people down. but also says, you're not helpless. And that's important. I want to put a pin on that. Your institution participates every day in either reinforcing or relieving that grind. That's the fork in the road. And nowhere is that more visible than in maternal health. So another part of the process is to focus on weathering in relation to maternal health specifically and why age patterns flip. Well, let me explain that. Let's connect this directly to pregnancy and birth. Chronic exposure to racism, discrimination, economic hardship all accelerate biological aging and increase rates of hypertension, diabetes, and other conditions that complicate pregnancy, and especially at younger ages, far younger ages for Black women. And in the other episode, we heard from Arlene Geronimus's work that shows something striking. Black women may have worse pregnancy outcomes in their mid-20s than in their late teens. Well, the opposite pattern is seen in white women. So the insight is more years of living in marginalizing environments means more weathering. That flips the script. And it tells us that the usual advice, wait until you're older and more stable, doesn't land the same way in bodies that have already been physiological aged by systemic racism and economic stress. Weathering connects directly higher rates of severe maternal morbidity, higher risk of preeclampsia and eclampsia and hemorrhage, and higher rates of preterm birth and low birth weight. Disproportionate maternal morbidity for Black women and women of color is basically 2x if you're Black or you're a white woman going through pregnancy. When you add pregnancy on top of years of weathering, you're asking already overtaxed bodies to carry a huge additional load. And then we layer on top of that workplaces that basically punish pregnancy, health plans that make access to basic prenatal mental health care a maze to trudge through, and delivery systems that still dismiss women's pain, especially Black women's pain, as exaggeration or maybe anxiety. And so it's not surprising that outcomes diverge. It'd be surprising if they didn't, wouldn't it? So if you're a health plan leader or hospital executive or an employer listening to this, the question is not, why are women making such bad choices? The question is, what choices have we as institutions of making that turn normal reproductive physiology into a game of Russian roulette for some women, but not for others? So we need to be practical. Well, let's look at the employer's role. The question is, are you part of the cure or are you the weather? The employer is often the first time in either interrupting or reinforcing weathering long before anyone talks about prenatal care. And the key question is, do you offer maternity benefit? No, that's not the first question. That should not be the first question. The first question should be, do your pay structures, your schedules, and your expectations make it biologically expensive to work for you while pregnant or parenting? Do you treat pregnancy as a temporary inconvenience to be managed or as a predictable, normal part of your workforce's life that you design around? When women of color tell you they're experiencing bias and unsafe conditions or retaliation, well, do you treat that as a core risk to your business or as an HR issue to be complained? Because if you want to reduce weathering, here's what that can look like in practice. You redesign jobs and schedules so pregnant workers don't have to choose between income and health. And that means predictable scheduling, sane workloads, and real accommodation that don't just tank someone's career. You make paid leave and pregnancy-related accommodations standard and stigma-free, especially for lower wage workers, not just professionals. You train managers to recognize and respond to weathering-related realities like chronic fatigue, caregiving stress, mental health strain, without defaulting to punishment or skepticism. You use your role as a purchaser to push health plans on maternal equity and weathering aware benefits, not just on premium trends and narrow networks. So here's a probing question I think every C-suite should sit with. If we invited cross-section of pregnant employees and new parents to talk to your board about whether working here is buffering or intensifying the weathering in their lives, what would they say? And are you sure about what they would say? And if the answer makes you uncomfortable, well, that's where the work begins, right? So one of the most important areas to focus on is health plans, not just employers. And whether benefit design is a stress amplifier or a pressure release. Again, a stress amplifier or pressure release. Now, health plans often sit behind the scenes, but their decisions are felt in the body every day, every denied claim, every confusing bill, every in-network dead end. And from a weathering perspective, those frictions aren't just annoyances. They're the hits to the blood pressure, to sleep, and mental health in people whose systems are already running hot. So I'd pose 3 sharp questions to health plan leaders. 1, how many of your utilization management strategies rely on making it harder, more confusing, or more time-consuming for people to get care, especially with the least amount of bandwidth to spare? Second, when you design high-deductible plans or narrow networks, do you account for the fact that the physiological cost of navigating those barriers not the same for everyone? And third, do your maternal health programs directly target weathering by reducing financial barriers, embedded trusted community workers, and integrated mental health? Or do they simply layer coaching on top of a stressful status quo? So if plans want to be part of the solutions, here are 4 specific things to consider. Strip out unnecessary prior authorization and cost sharing for core maternal services and supports. And that includes prenatal visits, ultrasounds, lab work, mental health, doulas, and postpartum care. Intentionally fund doulas, community health workers, group prenatal care, and mental health services in communities that bear the brunt of weathering. And tie contracts and bonuses to improvements in maternal equity measures. What are these? Well, severe maternal morbidity, preterm birth, postpartum visit completion, not just program engagement metrics or generic HEDA scores, and use their data to identify weathering patterns like zip codes and age bands and racial gaps where complications tend to cluster, and then change benefit and network design accordingly. And then there's the uncomfortable self-audit. If your own staff had to use the maternity benefit while working full-time, caring for relatives and living with chronic discrimination or poverty, would they walk away more or less weathered than when they started? And if you don't like the answer, well, that's the roadmap to follow. And the final focus is on delivery systems. Are they treating weathering or punishing it? Hospitals and delivery systems often see people at the at the moment when weathering becomes a crisis. Again, eclampsia and hemorrhage and cardiomyopathy and suicidal ideation. The temptation is to focus entirely on clinical rescue and then post-event review. That's not where the action is. But because for weathered patients, the way your institution behaves before, during, and after childbirth can either magnify harm or actively heal. You have a choice. So here are 3 probing questions I think the boards and clinical leaders need to wrestle with. First, do your triage, admission, and discharge process assume a patient feels safe, rested, and trusting, or if the patient is exhausted, afraid of being dismissed, juggling multiple threats outside the hospital? Do clinicians have the time, the training, and support to see weathering in the room, in the exam room, in the treatment room? Understand that a patient's attitude or hesitation or lack of follow-through might be a survival response to years of being ignored. And is postpartum care treated as a box-checking formality or as a clinical window to address the cultural, the clinical, and mental health consequences of weathering before they become tragedies? Now, if delivery systems take this seriously, maybe take the following 4 actions. First, build respectful maternity care and trauma and healing informed practices into standard workflows, not side projects. Listening to patients' concern, honoring preferences, and inviting support people or doulas into the process. Extend care beyond discharge and proactive postpartum follow-up, home or community visits, and easy entry into mental health and social support. Now, this means multiple touch points in the first 12 weeks, not a single 6-week visit. And integrate community partners, the doulas, community health workers, and local organizations, and integrate them into perinatal care teams and governance structures, not just as nice to have add-ons. Track not only clinical outcomes, but also patient experience, especially for women of color and those in disinvested neighborhoods, and then act on what they learn. And the hardest question of all to look at, when something goes wrong, like a death or a severe morbidity, do you treat it as a one-off failure of a protocol or as a signal that your institution is still part of a broader weathering machine? If we only respond with another checklist, we may be missing the point. And finally, let's close with the question, is anyone actually paying attention? That's a legitimate question. Right now, a small but growing number of clinicians, researchers, advocates, and community organizations are talking explicitly about weathering and what it means for maternal health. Some are making changes to line up with the weathering framework, even if they don't use that same language. And you can see it in early investment in doulas and community health workers. You can see it in redesigned postpartum care models and better protection for pregnant workers. You can certainly see it in benefits that finally shrink financial and logistical stress instead of adding to it. But at the level of mainstream corporate and healthcare leadership, weathering hasn't entered the vocabulary yet. Many boards and C-suites still prefer safer terms like, again, resilience, burnout, or even social determinants. Words that don't force them to confront how their own decisions age bodies prematurely. The danger is that we file weathering under interesting concept, we nod to gravely one another, then return to business as usual. But this opportunity is different. The opportunity is to treat weathering as a new standard of accountability, I want to repeat that, as a new standard of basic accountability, not just what are our maternal mortality rates. So the focus should be on how much cumulative wear and tear are our policies adding or removing from the lives of people we employ, insure, and treat. That's the harder question. It's also one that tells you whether you're in the weather business or you're in the health business. So if you're a leader listening to this, I'll leave you with maybe one big challenge. If you were to add one explicit weathering metric or commitment to your organization's maternal health strategy this year, what would it be? And who would have to change for it to be a real rather than a rhetorical? Would you commit to zero cost shaving for core mental and maternal health services in the highest weather communities that you serve? Would you guarantee paid leave and pregnancy accommodations for your lowest paid workers, not just your executives? Would you embed doulas and community health workers into your perinatal teams and give them real authority? Whatever you choose, it doesn't lower the baseline stress in people's lives. If it doesn't, then it's probably not about weathering. Weathering is how people's bodies pay with their health for surviving in an unfair, unjust healthcare system. Even broader, the system that we all live in. Our job, if we're serious about maternal health, about equity, about more health and less sickness care, is to make it less biologically expensive simply to live your life, get pregnant, give birth, and raise a child in our society. Not by telling people to be tougher, but by changing the conditions that are tough within. So thank you for listening. I know this is a lot to take in one episode, and we'll go into much more detail in the coming weeks. But if this conversation sparks something for you, if you're seeing weathering in your patients, your members, or your workforces, I'd love for you to sit with that one question. Are we slowing the damage, or are we quietly helping it along? So this is Peter Bold. I'll see you next time on More Health, Less Healthcare. Thank you for listening.